Good morning and welcome to today's webinar, Handoffs, Don't Drop That Baton. I am Delene Murray with Optima Healthcare Insurance Services and your program moderator today. As you well know, handoffs can have a huge impact on the care patients receive. Our speaker today has observed numerous handoffs at multiple hospitals. She will be sharing her summary of how and where the less than ideal handoffs occurred and discussing ideal policy elements structuring handoffs. But before we get started, please note that you can chat in questions at any time during the presentation, and we will address them at the end during the question and answer session. Notice in the lower right corner of your screen, there is a web links box. You can access the sign-in and evaluation by clicking that link. Please don't complete the evaluation until after the presentation is complete. Another option for the evaluation and sign-in is to stay logged on at the end of the webinar. When I close the meeting, you will automatically be taken to the evaluation and attestation of attendance webpage. Jean Turvey is our speaker today. Jean is a Vice President, Clinical Risk Management Consultant in the Health Practice Group at Baton. She has over 40 years of healthcare experience in clinical practice, risk management, quality assurance, performance improvement, infection control, and ethics and regulatory compliance. Jean has held leadership positions of Chief Nursing Officer, Chief Operating Officer, and Ethics and Compliance Officer. She has held staff and leadership positions in a variety of healthcare settings, including acute care hospitals from small rural to urban academic medical centers. She has also practiced in home care and nursing staff relief organizations. So she has extensive experience in a wide array of handoffs herself. Jean has also provided educational offerings on a variety of risk management topics and was a presenter at the American Society for Healthcare Risk Managers, a division of American Hospital Association, and also known as ASHRM, national conferences in 2006 and 2013. She is a member of multiple professional organizations supporting her dedication to mitigating risk and strengthening healthcare quality. And with that, welcome, Jean. I'll let you get started with today's program.
Thanks so much. I'm really grateful to be able to do this. I'm back in the Midwest today. I wish I was where most of you are, out on the West Coast. I was working out there a couple of weeks ago, and the weather was gorgeous. But it's getting ready to snow here today, so there you go. My bio makes me sound like I'm 100 years old, and I kind of am. My best friend in the world works for Optima, and it's just a luxury to be able to speak with you and share with you some of this information. I'm happiest when I'm working in hospitals and working with healthcare professionals, so let's get started. So, well, let's see if I can get these slides to drop down here for me. There we go. All right, objectives. We're going to talk about components of an effective handoff, formats for handoff communication, and types of communication in handoffs, and of course the value, which most of you already understand, and the merit of bedside handoffs. I have been a nurse, as Elaine said, over 40 years, and learned a lot in that period of time. I have, you know, they say about real estate that it's all about location, location, location. Healthcare is about information management. It's all about information, information, information. Yes, we lay hands on people. Yes, we bring ourselves to the bedside. Yes, we bring technology and very high power science and very great minds to the bedside. But it is about information management, at least when we're talking about handoffs and the work that you and your staff do day in, day out. So what is a handoff? And I'm really doing some of the basics here, so forgive me if some of you know this even intuitively, but there are two different phrases that you see in the literature related to handoffs. One is handoff and the other one is sign out. And so I refer to a handoff as transferring responsibility for care, either shift to shift or unit to unit, as a patient moves through your continuum of care. Even transitioning in and out of facilities, acute to subacute, acute to long-term care to acute, although that's an interesting handoff that often doesn't even exist. But anyway, handoff, transferring responsibility for care. Sign out. I was sort of raised as a nurse in the 70s in an academic medical center and became accustomed to the phrase sign out mostly between physicians when the physicians were going off duty, off of their shift or off of their rotation, and they would sign out a patient, or to a physician who was covering for them or was going to take call for their service overnight. So in my mind, a sign out is a little bit different than a handoff. However, if you read handoff literature, you will see them use the phrase interchangeably in some of the literature. And I'm not sure I agree with that, but either way. I'm looking, let me stop period just for a moment and say I'm watching the chat box and people are having a hard time hearing me. So send me another note if it got better. I've adjusted my headset. And if it doesn't work, I'll pick up my handset for you. Okay.
I think you sound better.
Is that better? Okay, thank you. I apologize for that. All right. Sign out and handoff. So are they interchangeable? I'm not sure it really matters at the end of the day, but just know there's two phrases out there, and they may be used interchangeably or not. Either way, it's a high-risk event because we're talking about probably important, hopefully, and critical information about the patient that's being cared for at the time. The impact of adverse patient care events, the number of critical events or sentinel events that occur as a result of a poor handoff, that's well publicized. So maybe a third of sentinel events, maybe 80% of all serious events. So I'm going to pick up my handset. So let's try that. All right, so hopefully that'll be better for all of you. Thank you, and I apologize for the technical issue. So maybe a third of sentinel events, maybe 80% of all serious events. And either way, that's soft data, but either way, you get the picture. And I'm sure in your own organization, you have seen events that have had at least one component or a critical component of a lack or a poor handoff communication. Handoff, ensuring safe passage for patients. So communication is challenging in the best of circumstances. And if you are a nurse manager, nurse director, have responsibility for a patient care unit that's busy or a whole facility that's busy, if you listen to the noise, just the ambient noise, then that's a challenging environment to work in. I have to say, over the 40 years or so, more that I've been doing this, the healthcare environments have gotten quieter, and so I'm grateful for that. There have been fewer overhead pages, certainly, and so the units are usually quieter than they've been for many years, so that's helpful. But we still have a lot of interruptions, and then there's always the noise in our heads, right? Yeah, there's always the thinking processes that are going on, the multitasking that's going on. And so no matter what's happening in front of you, your brain is always getting ready for the next thing or the next task or then what, then what, then what. So it's still a very challenging environment to work on. And what also happens during handoffs is socialization between staff. If it's unit to unit, maybe you don't see each other very often. Maybe there's some education going on. Maybe there's some emotional support going on. So there's a lot of secondary stuff that's happening during handoffs when staff are talking to each other. Now, I think that's a good thing at the end of the day. I've been doing this long enough that I've seen a variety of ways that we have tried to manage the handoff or structure the handoff. For example, in your emergency departments, The throughput is king right now. How quickly are we getting patients from the front door of the emergency department all the way into an inpatient bed? So what are all those increments of time? And your ED directors all know those increments of time in their heads, which kind of scares me. But they know bed to triage, bed to the back, or patient to a provider. Then we're watching that time period, hopefully, from the time that the decision is made to admit a patient. How long does that take? So to speed those transitions up, that throughput up, to speed throughput up through the emergency department, we have used a variety of ways to get that handoff done up to the inpatient units. Now, I'm an old med-surg nurse. I've done all kinds of nursing, but most of my time was spent at the bedside in med-surg. And so when the ED tells me that they have trouble getting report to the med-surg nurse because they won't take the call, they're too busy, they're at lunch, whatever it is, I try to tell them, don't tell me about those games. I wrote most of those games. But we've tried a variety of ways to do that handoff, to speed up that communication with the receiving unit. My least favorite is we have faxed report. Holy moly. Okay, so the ED will fax report up to the inpatient unit, and then in some cases they will just move the patient to the bed. They won't talk to anybody. They just rock. They just take the patient to the inpatient bed. That is not a successful handoff. We have tried, and we still try in many cases, to have the inpatient nurses, either the ICU or the med-surg units, look in the computer to get report about the patient. So we've tried a variety of ways, most of which, at least from my risk management point of view, are highly successful. They don't have the opportunity for a successful handoff, and it's going to fail. So anyway, we've tried a variety of creative ways. And when we do that, we fax report or we tell the bedside nurse, just look in the computer, the information is all there. No, it's not. Then we don't get the opportunity to socialize with them. We don't get the opportunity to do education. We don't have the opportunity to give them some emotional support for whatever's happening in the world at the moment. But what we really don't have the opportunity to do is give them complete, thorough information about this patient and their care needs right here, right now. So that handoff and how you do it is very important. And if you don't have an adequate handoff, then there's no rationale for decisions that have been made or will need to be made, maybe very shortly, about that patient. The receiving caregiver is less prepared to anticipate problems with this patient. And then there are certain uncertainties and ambiguities that will arise. And I think that second bullet point, they're less prepared to anticipate problems. From a risk management point of view, that's of critical importance to me because you're passing a sick person from one point of care to another point of care, and the person who's receiving them does not really have much time to go through the electronic record, to look at what's been given, to look at what's been happening with them, to find out their kind of the whole picture about them. Then they're least prepared and have very little time to take care of something urgent or certainly something emergent that might arise with them. And I do want to remind you, and you know this intuitively, when we went from 8-hour shifts to 12-hour shifts, then we went from 3 handoffs a day to 2, and that's a good thing. Less opportunity for, let's just call it what it is, less opportunity for screw-up. So we've had less opportunity for important information to drop between the cracks. So that's a good thing. Now, some of you are still working 8, some of you are working 10s. There are a variety of creative shifts, but the bulk of you have gone from 8 hours to 12-hour shifts, and that's what I see in the field as I travel the United States for our clients of the brokerage that I work for, which is the locked-in companies. So when do handoffs occur and how often do they occur? Well, oh my, the numbers, again, are very soft. I'm just going to scroll down through these. Wasn't sure I knew there was so much animation in these slides. animation makes me a little nuts. But anyway, all right, nurse to nurse, yep, we get it. Nurse to other departments, nurse to physician, physician to physician, and again, I'd kind of use that phrase sign off. Professional to professional, from PT, OT, ST. I don't want to just limit this to nurses, certainly. Meal breaks, when and if your staff get meal breaks, and they don't always. Physician to nurse, coming back at us, right? Critical lab results, there's a big one. Critical radiology results, that's another. Passage of information, it's a type of handoff. Transfers between units and transfers to other facilities. As I'm in the field and I talk with staff, and that's really what Millie and Deline were interested in as I prepared to give this presentation, is what have I seen around the country in handoffs? What have been my observations? We do pretty well, or we're getting better, hopefully, within the facility. We don't do as well from our facility, particularly acute care facilities, out to long-term care facilities. Then we start to, then that handoff importance starts to kind of fade away. The one that's a surprise to me in particular, and I'll ask you to think about this, and I'm not familiar with all of your facilities that are on the line today, so you'll have to think about this and within your scope of responsibility and authority. The one that's been a surprise to me is when I've been out in physician practices, whether or not, and it doesn't really matter to me, I focus on the patients. That's all I care about really is the patients, all right? When I talk to clinic nurses or clinic staff, and clinics are not always staffed by nurses, they're staffed by medical assistants very often, more often than not, they're staffed by medical assistants. But either way, excuse me, when I talk to clinic staff and I ask them, what kind of report do you give to the hospital when you're sending a patient from your office into the hospital for admission? And they give me a blank look. Like, why would I do that? And then they say, well, the doctor, calls the hospital and tells them that the patient is coming. And with all due respect, that's probably all they tell the hospital. So there's not much of a handoff coming to y'all when you get a direct admission out of the physician office, and I have some concerns about that. If that clinic is not owned and operated by the hospital, then you may not have tons of opportunity to impact that transfer of information. But if you do, in particular, if these are employed physicians or if in California that's not the case, but if the clinic is owned or operated by the hospital or has a lot of referrals coming in or admissions coming in from that office, maybe you have an opportunity to say, we need more of a handoff, because what is the impact to the patient when they come rolling in a wheelchair and they hit your unit, particularly if they have bypassed the emergency department? They are not packaged and ready for admission, and you may not have very good information. And is that really good for patient care? So my brain would say, no, not so much. So see if you have any opportunity to impact that. All right, so let's move on here. All right, so frequency of handoffs. Whoops, in a hospital with an average daily census of 400 and nurses working 12-hour shifts, there may be close to 3 million change of shift handoffs occurring every year. Would you ever have contemplated that the number would be that big? Yeah. So daily census of 400, maybe 3 million change of shift handoffs. Now, if you've got a daily census of 100, all right, then divide that by 4. But regardless, we are talking about a lot of change of shift handoffs. So this is a big darn deal, right? That much information, critical information, changing hands all the time. And that number doesn't include your interdepartmental handoffs, handoffs between departments. So the process of a good handoff, it's a two-way conversation. It should not be one way. That's why I don't like faxed handoffs. That's why I don't like nurses being told, just look in the computer, the information is not all there. That dog won't hunt with me, all right? It's a two-way conversation. And the receiver has the time to ask questions. That's so important, or at least to process what you're telling them and think through if there's anything else they need to know or want to know about the patient that they're receiving. And Also, a good handoff includes the most recent data and information about the patient. Think about the length of stay of these patients in your hospital. The average length of stay that I see now in most acute care hospitals has dropped below 3.0 days, which just makes me shake my head. 3.0 days. And also think about then, how well does the receiving caregiver, do they know, let's say a patient's going from the emergency department to an inpatient unit, okay? Let's think about that. Now, this is just ED nurse to, let's say, med-surg nurse. So that med-surg nurse does not know this patient unless they are being readmitted frequently. So this is brand new to them. But even shift to shift, okay, with staff working majority of the time now, 12-hour shifts and a length of stay of 3.0 days, how many shifts has that nurse potentially worked with that patient? Not many. 3.0 days, 12-hour shifts. So you're lucky when you're giving shift report within a unit that that nurse has worked with that patient before. So they don't know the patient at all. Again, increases the value and the importance of good handoff communication. And a good handoff also includes any changes that may occur with this patient, and if so, then what? Then what would be necessary? Then the receiver of that information needs to verify that they understand. And are we talking about read back? No, probably a speak back or report back. Say, yes, okay, yep, got it. I think I've got everything I need to know. And the receiver has appropriate time to review maybe some history, previous care plans, treatments, and all that sort of thing. So now I also look at handoffs when I'm in facilities, maybe in PACU. That's another excellent handoff that we can talk about if we have time. For all of you people that are on the line now, regardless of what your role is, and you're not all in inpatient units, I understand that. We have some care navigators. We have different types of roles and responsibilities included. Think about what you do and where you work within the facility, and both the handoffs in which you participate, but also handoffs that you observe. And if you're a manager, think about the handoffs between people that you're responsible for. The only way you're going to get a good appreciation whether or not the processes of good handoffs are complete and thorough and accurate, you're going to have to observe. You need to get out there and listen and watch. And that's what I do when I'm in the facilities. Yep, I've signed a BAA with these facilities, and I'm out there listening. I'm listening to shift reports. I'm listening to patients going from one unit to another. I'm listening for the report of patients coming out of the cath lab into the ICU, from the ED into the cath lab maybe. So between departments, from the med-surg unit into radiology, that's a good one. The only way that you, within your scope of responsibility and authority, the only way that you're going to know whether or not the handoffs are occurring the way that they should be, the way that your facility expects them to occur, the way that your policy states they will occur, and the way that you believe they occur. The only way you're going to know is by supervision, is by listening and watching these handoffs. So I really encourage you to do that. In most of my on-site assessments in facilities, I spend a lot of time in conference rooms like your surveyors do, your state regulators, the Joint Commission, whoever is an accrediting agency if you have one. They spend a lot of time in conference rooms, and so do I. However, when you want to know about handoffs in your facility, the only way you're going to understand is to get out there and listen. And so I spend 8 or 10 hours on my feet in facilities watching and listening. And I'm watching both sides, the information that's given, and then how the person is receiving that information and whether or not they understand completely and thoroughly. And listen for interruptions. Watch for interruptions. All right, handoff content. What is it that we're supposed to be talking about here? Demographics. Who is the patient? What's going on with them? Their condition, their care. What treatments are they getting? Medications that are important. The last assessment that's relevant to their diagnosis and a procedure that they've had or that they're getting ready to have. And what's the plan of care? Things that have happened with them or things that could happen with them. Help the receiver anticipate changes that could occur. All right. What influences handoffs within facilities? Most facilities that I'm in now have some kind of policy or procedure about communication, and their policies will talk about what type of handoff they use. What do I ordinarily see? Let me just put it out there. What I ordinarily see used as the word for how we do handoffs is SBAR, and I'll talk more about that through the presentation. But the policy of the hospital or the facility, the organization, is an important part. What is the structure? How do we expect handoffs to occur? So certainly that is a strong influence, or should be. Okay. Beyond that then, is this a facility that has very open communication or not? Facilities have different styles. They have different, there's kind of a rhythm to healthcare. There's a feel for it. When you walk into facilities, you kind of sense it. You know whether this is an open facility or whether a very formal, very traditional sort of shut-down communication style. Facilities absolutely have different cultural values related to feedback and communication about errors. And do staff talk about processes and things that we can do better? Yes. Teamwork within units. Do I need to say anything more about that? I'm getting ready to go to North Carolina next week to look at an emergency department. And one of the things that I will do is interview other departments about the ED, and I will ask the ED staff about the other departments. How is the teamwork between the units and across the units? It's important. So teamwork within a unit, again, there's a rhythm to that. Is it a stable, mature staff that communicates well with each other and the care kind of proceeds like it's on greased rails? Or is it kind of clunky, and if you've seen one shift, you've seen one shift, and it's just not a smooth running unit, and they're using a lot of agency, a lot of traveler staff, a lot of turnover, very dysfunctional unit, or again, very smooth, flowing, good rhythm to the unit and the health care that's being provided. And then, of course, across units, because, you know, handoffs are occurring within a unit and handoffs are occurring across units. So both of those, the teamwork is a very strong influence on the quality of the handoff that's being given. Management support for patient safety. All right, well, broadly, of course, that would influence the handoff, but directly influences the handoff. If you are a manager of any type of caregiver, what is your message to the staff that you supervise? You will only get the behaviors that you are rewarding. I can't tell you how many times I've asked staff when I'm out in hospitals, do you do a bedside shift report? And sometimes the answer is yes, but only when my manager is here. All right. Yes, we only do it when the manager is here. Now, that probably, unfortunately, not only applies to handoffs, but it may occur to other patient safety behaviors as well. They only do it when they're being watched. They are humans after all. But management support, where is the importance of the handoff communication? How is that communicated to your staff and that expectation, all right? Expectation is important. And how do you handle errors when your staff commit errors? Is it a punitive response? Are they in trouble for everything? Is it a fearful environment? You can feel that as well when you're a stranger walking onto a nursing unit. You can just feel it, okay? And do you lead by example? If you are a manager of a department and you're going on vacation, who's covering for you while you're gone? And have you done a handoff? That's a question that you and only you can answer. All right, so where are the breakdowns? Well, expectations may differ between senders and receivers of patients in transition. Let's say it's a patient in the emergency department moving into the ICU. The ED's expectation is to get them out of the to get them out of the ED. The ICU's expectation is they are receiving a complicated, critically ill or hurt patient, and so their expectations are different. ED's in a hurry. ICU may be in a hurry, but they may be in for it with this patient, and they know that. So expectations are different. Maybe there is no standardization within the facility. Maybe the facility has not said we're going to structure our handoff communication in a particular way. I go back to SBAR. Facilities tell me they use SBAR. The truth is they don't. I learned SBAR in a setting which communicated to me that the purpose of SBAR really was not a handoff necessarily. It was a structure for talking particularly to a physician over the telephone. I hate to classify patients caregivers by what they are not. I hate to call people by non-physician. That makes me nuts. But I got to tell you, when non-physicians are talking to physicians, it's important that they understand communication styles and how physicians organize information. So non-physicians tend to organize information differently than physicians. And that's my opinion, but anyway, that's what you asked me for. Okay. Physicians are listening for the headline, and what is the action item? What are they being asked to do specifically at this moment? When a non-physician calls a physician about a patient in particular, or approaches them on the nursing unit or another department, you could be a physical therapist needing orders for a patient. When a non-physician approaches a physician, the non-physician tends to tell the story, and they eventually get to the question posed to the physician. All the time the story is being told, the physician is listening for the action item. What is it that you need from me? Okay. So SBAR, at least in its history, was intended to communicate better with physicians. So, doctor, I'm caring for Mrs. Turvey on the nurses unit. She has a history of cardiac disease and thyroid surgery, and she is presenting with fill in the blank, and this is what's occurring at this moment, and I need an order for fill in the blank. Okay, so it's situation, background, my assessment, and really recommendation, or what is it that I need from you at this moment. So at least it structured that communication style and the order in which the information was given. That, in my opinion, the SBAR conversation is a little different than the handoff. But I'm not critical that hospitals are trying to structure handoffs. Actually, I'm very grateful when they do that. I think and this is again my opinion, and it may or may not match your perceptions or the reality in your organizations, SBAR has become a rather generic phrase to mean handoff. So SBAR has become sort of the equivalent of, yes, we use a standardized handoff mechanism in this organization, but when you listen to the handoff then in that hospital, you don't always hear the SBAR structure. Sometimes you do. Most times I don't. I don't hear the SBAR structure. What I tend to hear, that maybe they've modified it to an ISBAR. Maybe they're using the IPASS. There are other types or the order, the linear flow of information flowing from one person to the other. But it doesn't always follow the SBAR format exactly, okay? But at least hospitals have been trying to standardize handoffs. So that's a good thing. But when it's not standardized in an organization, and I still find organizations that it's not, or they say it is, but staff are not following the intent of administration and policy and procedure. When there's a lack of standardization, then handoffs are all over the board. So maybe the institution's culture is not promoting successful handoffs. Again, lack of teamwork, lack of respect, very low expectations. Maybe that quality bar is set very, very low, okay? Maybe the priority is something else. And maybe there's just inadequate amount of time allowed for successful handoffs. Some of that goes back to staffing, I got to tell you. And we know the literature is full of really very evidence-based research that says that a lot of quality is linked back to staffing. I hate like blue blazes to ask staffing questions when I'm in organizations. I am an old chief nurse, an old chief operating officer. I can talk a bit with the best of them. I get it. I know man hours per patient day. I know the pressures that are involved there. So time is critical. And maybe staff are working short. Maybe they just don't have time to do a good handoff. So that's very important influence on the success of handoffs. All right. And we know adverse events are frequently due to incomplete, inaccurate, or omitted information. Checklists are good things. Checklists are very helpful. They help us structure. You'll laugh. I have a checklist at home that I've been traveling for this job for 12 years. I travel all the time, fly nearly every week. And I have a checklist that I check every time before I'm out the door. I mean, really? But you know what? If I don't check that list, I leave something behind at home every single time. Checklists cannot replace critical and narrative thinking. They still won't. They're very necessary and important, but the critical and narrative thinking are still required. So faxed handoffs, look in the computer, don't do it for me. I hope by now that you have heard me say that, and if that's how you're doing your handoffs, that frankly you rethink that in the future. Interruptions, the handoff period for interruptions, if possible, should be, I think, along the lines of the sterile cockpit that we're using when we're trying to set up medications, right? So we've understood the importance of interruptions and how interruptions make the medication administration, or at least the medication preparation process, they can make it very problematic, and error-prone. So interruptions during a handoff equally can destroy the value, or at least the thoroughness, of a handoff that's happening. Again, lack of time if we're rushing it, and unclear anticipatory guidance. If I'm handing off a patient between two caregivers, and the caregiver that's been taking care of the patient, that understands him or her the best, doesn't give that good anticipatory guidance to say, if this happens, then that. Jean is an insulin-dependent diabetic, and her blood sugar tends to go down at 2 o'clock in the morning, so please be watching for that as you're making your rounds during the night. Anticipatory guidance is really important for patient safety. So liability risks. Yep, I do work for an insurance broker, so that's really important to me. There's plenty of case studies out there that have shown dire consequences to a patient with a poor handoff. 29-year-old male with brittle diabetes admitted for incision and drainage of a leg wound, and you can read this. I won't read it to you. But basically, the nurse was unable to accompany this patient, but informed the transportation assistant about the patient's extreme sensitivity to insulin, And so we had dire consequences with that patient. The risk of bending the rules. All right. So even in a hospital or an organization that may have structured communication, structured handoffs, we may not do it. Like, my manager's not here, so I'm not going to do a bedside handoff at the moment. Why do caregivers bend rules? And this can apply to standards and guidelines across the hospital, not just to handoffs. Why do caregivers bend rules? To get her done, right? We've got a lot to do. We need to get it done. What's the difference between a workaround and bending the rules? Well, sometimes workarounds are necessary when things aren't working exactly right, and it's an intentional decision that we have to do it this way to get it done, and we acknowledge that it's a workaround, but we're not really bending a rule because that's going to be our intent. That's how we're going to do it going forward, is bending the rule. So we may not know the rule, we may not know the policy or the regulation, and sometimes staff believe that their professional judgment really overrides the policy. Well, yeah, that's the rule, but I want to do it this way because I think it works better this way, and that's how we're going to do it. So rule bending is a learned behavior, and we tend to repeat the rule bending over and over and over, like not giving the handoff the way that we're expected to. And so that becomes a learned behavior, and it becomes culturally acceptable. And then when you're either overtly mentoring or training others on the unit, they learn to do it the way you're doing it, which is wrong. And there may be people that are watching you and learning from you, and you don't know they're watching and learning from you, and they start to do it that way as well. So rule bending becomes culturally acceptable, and then we have a problem, all right? So what's responsible subversion? Yeah, so we're stepping outside of the rules. We're stepping outside of the rules of their practice, and again, as new caregivers come into your unit, then we learn how they handle certain situations, and the rule bending continues. I saw that happening once in a unit that I was asked to assist. They'd had a very large morphine diversion, and you say to yourself, how in the world could that have happened? Well, it was because they were sharing their passcodes into the Pyxis machine, and they were sharing passcodes, and then somebody stole a bunch of morphine under other people's passcodes. I mean, you think, oh, that can't be true. Yep, that's how it happened. They were rule bending to get around a certain procedure, and then we had an unintended consequence. Yep. Okay, this is what I hear. Well, we're supposed to do bedside shift report, but, well, we do it sometimes. Or, no, we don't do that. Or we do it when the nurse manager is here. Or we used to do it, but we stopped because we got busy. Or we do it unless we're busy. Or I do bedside shift report, but nobody else does. All right. So as I said, if you are responsible for other people, then I would suggest that you watch their handoffs, you listen to their handoffs, and then you correct as a manager when those handoffs are not successful, when they're not thorough, when they're not complete, when they're not following the rules, quite frankly. This one drives me crazy. Patients referred to as bed numbers. If you are working in an acute care hospital and you want to know if patients in the hospital are referred to bed numbers, go to radiology and ask them. Ask the x-ray tech. Does the ED ever call and say, I need a chest x-ray in bed 3, all right? What happens with handoffs and with this, bed 3, what happens is staff will tell you that they don't do that, but when you listen, they do, all right? So referring to a patient as a bed number is a setup for an error. It's when radiology does the wrong patient, when they take a film of the wrong patient, sometimes it's because of this. The patient is misidentified as a bed number, not by their name and date of birth. Handoffs, you may see and hear handoffs that are inconsistent. And this, I want to take a moment to talk about nurse brains. This is really a fascinating observation, and I'll be very honest with you, I don't know what to do with it. But I'm going to pass it to you, and you can think about it for your facility. Yes, we are in electronic health records right now, and nurses are still using what we call brains. They still use worksheets. They still use a piece of paper because they have to. They're trying to keep track of the details of all of their patients. They're taking notes on pieces of paper. I'm not critical of that. It's just how we do it, right? And there are different formats within hospitals for nurse brains, and I don't know what else to call them. That they're worksheets, they're pieces of paper, but they have a structure to them. And so a nurse has a place where he or she will write the patient's name, their bed number, maybe some significant times of medications that are due, maybe they're going for a procedure, whatever it is. Nurses are taking notes on pieces of paper that are structured, and they're all different. Now, so how the handoff is given verbally between units or within a unit at shift change, those handoffs should not be as variable as they are. We're trying to reduce some of that variation, make it very anticipated, what information is going to come at me when I'm getting a handoff. And nurses are taking notes on these brains. What's different is the structure of the brains that they're using. Some of them have their own brains that they've created, and they keep copies of them. They keep them in their lockers, or they keep them in their bags. They bring them to work with them. Yeah. So, for example, in one nice hospital, it was under 200 beds, but it's not tiny. It's not huge, but it's not tiny. I personally got a hold of over 30 different worksheets that the nurses were writing down notes on about the handoffs. Over 30, okay? So I don't know what to do with that. I've not had that information long enough to try to figure out some good recommendations related to that. But my brain tells me that if we're expecting to reduce the variation in our handoffs, make that more standardized in hospitals, doesn't it make sense that we could give nurses a more standardized format in which to take some notes about the patient because the information is going to come at them in the same order? Yeah, okay, but I don't have the answer to that. It's somewhat rhetorical at this moment, but I'm passing that to you, hospitals, to think about that. And as you observe handoffs and develop expectations in your facilities, think about the worksheets that you're giving nurses or allowing them to use to take notes about their patients. Would it not be helpful if we standardize those? Now, all of that makes the IT people a little crazy because they think that we're working in electronic records and we're all going paperless. Well, yeah, not so much. Okay. Strategies to improve communication, tools and tips. All right. SBAR, well, there we go, the history and purpose of it. We've talked about it. SBAR really came out of other high-risk industries. Is there anything more high-risk than healthcare? Well, not personally, but nuclear submarines, the airline industry. And Kaiser first developed the SBAR and used it with a rapid response team in Colorado in 2002. So we're going on 20 years ago with that. We have added the I to it, the ISBAR, but it really does organize communication. And it is a narrative description. It does sort of highlight that action item for physicians or other providers during telephone calls or verbal handoff. And it also allows the non-physician, if you will, to make a recommendation to the physician. So it's a good thing. It's been a very useful thing. But in my opinion, hospitals are using it as a generic phrase meaning handoff. Well, yeah, we use SBAR. You do? Okay, now maybe they use a modified SBAR. So you identify yourself, that's the I. You identify yourself, you confirm who you're talking to, here's the patient, name, age, location, and then that structure for communication. So ISBAR is one. IPASS is another one, and they are teaching that in graduate medical education. And we say that it's used for sign-out communication between physicians. I think IPASS is probably closer to what we really do in shift-to-shift or unit-to-unit handoff communication. So when I hear people say they use SBAR, what they're really using is IPASS. But I don't care what you call it, as long as you structure it and you can predict the order in which people are going to give you information. So this is Jean Turvey in room 4. She's had a quadruple bypass. She's an insulin-dependent diabetic. She is stable through the evening. And then you go on with the rest of this information. This is her hospital course. She's on a very particular medication because she's got HIT syndrome type 2 following her quadruple bypass. This is what could happen in the middle of the night. Her blood sugar tends to crash somewhere between 2 and 6 a.m., and then the receiver synthesizes and summarizes what they heard. Yeah. So that's kind of the structure of IPASS. And as you look at that, that's probably the structure that most handoffs are occurring in your facility. IPASS the Baton is another one. It's a little bit longer. I am not, it's much longer abbreviation. IPASS the Baton. Frankly, if it's me, if I'm going to the grocery store for 5 items, I forget one of them. I can only remember 4. So if we have an acronym that's that long, I have more trouble remembering it, but maybe that's a training issue with your staff. So IPASS the Baton. That's another mnemonic for handoffs and healthcare transitions that some organizations are using. Okay? the handoff should have very specific information in it. It's part of that, what information should be anticipated about this patient. She's being discharged tomorrow, so you can start working on this, yes. Or indirect, if she has any Accuchecks below 60, then we're supposed to give another dose of fill in the blank, yeah. So the handoff should contain some very specific information. Other types of information, heads up, she has a PCA, but still saying she has pain at 10. But fill in the gap and give this contextually sensitive information, alerting caregivers about potential situations. That really is the risk management in the whole thing, helping the receiving caregiver anticipate what could happen with this patient, right? Verbal communication, certainly more thorough and really more in color rather than black and white about a particular patient. Bedside handoffs, I'm a huge fan. I mean, I am a huge fan. I cannot tell you, I cannot overemphasize the importance of bedside handoffs when it's appropriate, and it should be appropriate almost all the time. There are some situations, there are some units where bedside handoff has to be modified, or rarely it may not be appropriate at all. So I really don't accept excuses, well, we don't do it because fill in the blank. No, a bedside handoff is really becoming the expectation in many facilities, not in all. I would recommend it. I would reinforce it. I would make rounds to be sure it's happening. It's about patient safety. And I would encourage your staff that it's not about compliance. It's not about complying with a rule. It's about patient safety. If they know that that is your priority, then maybe they are more apt to do it. And you can involve the patient that way. I was probably not as aware of the importance of a bedside handoff until I was a patient in a hospital last year for 16 days. And so, as you may have suspected, some of those examples that I've been giving you were not really hypothetical. They were real for me. I had a quadruple bypass with a very serious complication of HIT syndrome, and frankly should not have survived. Rapid response team saved my life, but it was a very complicated medical stay, including a STEMI 5 days post-op. So it was all about the bedside handoff for me. The staff coming into my room, going over my medications, going over all the other things that were happening with me, and it's because of good care that I'm even on the phone today with you. So bedside handoff, very important. It'll reduce errors. The patients find it more engaging, more personal, keeps them informed about what's happening, keeps the family informed if it's appropriate. It's just more personal. And the risk management of the thing is not to be overlooked. We know that a personal relationship with the patient is a very strong protective mechanism from a risk management point of view. Patients tend to sue bricks and mortar, but they don't sue people with whom they have a relationship. That's not why you're caregivers. That's not why you're in healthcare to prevent lawsuits. You're in healthcare because you like helping people, you like developing that personal relationship with them, and so that's a nice benefit for us, is that we're able to meet people, help them, and make a difference in their lives, and a bedside report is just a small feature of that, but it really helps build that relationship. And again, nurses in particular, out on the patient care units, if they're working 12-hour shifts, man, they don't have many interactions with these patients in a 3-day length of stay. So we have to work pretty hard to develop a relationship with them. And a bedside handoff is one way to do that. Now, some patients won't want a bedside handoff, or it may be an inappropriate situation like a behavioral health care unit. So anyway, you have to respect their preferences or respect the context of the situation if a bedside handoff is simply not going to work. Okay, so I left 6 minutes for questions or complaints. I should have warned you.
Well, thank you, Jean.
If anybody wants to tell me to talk slower, don't even try. Yeah, you're welcome, Delene.
So thank you very much for an enlightening presentation. on standardizing the process for a good handoff, and then also providing some strategies to improve communication. So with us having a few minutes left, we will now take questions or comments from our participants. If you have a question or would like to share your successes or challenges regarding handoffs, please press #6 to unmute your line.
Hi, this is Millie, and I am wondering, Jean, if hospitals don't have a hospital-wide policy or form or whatever they're using for handoffs, do you suggest like everybody gets together and has input and then launch it one unit at a time, or how do you see that happening?
I really think I think Big Bang is usually a best approach for me, is to say, to get the management team together. I see I think without exaggeration, every hospital I go to now has huddles, safety huddles, and they're not necessarily, at least the management team has a huddle Monday through Friday, first thing in the morning, and that may be where you can initiate the conversation if a hospital doesn't have a specific mnemonic or a process for that, but that may be one place to start the conversation, and then agree on the mnemonic. And my favorite is the iPass. I think that's the most, I don't know, I think it's the shortest, it's the easiest to remember. And I guess theoretically, how could you pilot that on one unit, because handoffs occur between units? So I think you need to just Big Bang it and see how it goes, and tell people we're going to trial this for 30 days or 60 days, and then get feedback from everyone and see if it's working. So I think Big Bang the expectation, so that everybody knows what the expectation is, and we're all gonna try it. We're gonna all try to follow the same methodology or the order of information.
So there's a question in the chat box. Oh, thank you, Jean. There's a question in the chat box. Just press #6 to unmute your lines to ask the question. Jean, there's another question coming in. It says, what difference does it make what format a nurse keeps her notes in during her shift, as long as when she is reporting off, she uses the proper S-bar for the facility she is working?
It doesn't matter to me what order they keep their notes in through their shift. What's curious to me is as they are receiving information from the originating department, let's just say, for example, coming out of the ED onto the unit, they're jotting down the information in a all over the place in different formats in different ways, on vital signs and meds and condition and procedures and all that sort of thing. And so again, it's the structure. So if I expect the person who's giving report to structure the information, wouldn't it be easier for them to receive that information in the same order as they're jotting it down? During the shift, I don't care what they do, on their notes. They all have to do that different, whatever they do. But as they're receiving the information, to me, it's perplexing that they're jotting it down all over the place in different. What that says to me is they're not getting report in the same order. We're still not transmitting information in a left to right linear fashion consistently. If they did, I think everybody would be writing it down in the same order consistently. So I still think it's kind of a jumble. It's still a word jumble. During their shift, I don't care. I mean, I was famous for taking notes on paper towels, so whatever they want to do.
Thank you, Jean.
Yes, ma'am.
Anybody else with a question?
Yes, can we ask the speaker to provide some examples of how she's addressed what's in it for me, for the individuals at the bedside providing the shift report, and then also the what's in it for me with the emphasis on the ED's perspective, providing that two-way conversation during handoff.
What's in it for me? I think for what's in it for me, that's a good question. How do you get staff to do what they're asking them to do? Is that the root cause of the question? If it's about patient safety, it isn't about them. And so if they're there to provide safe care, I think that's an I get a little dogmatic, and so forgive me for that. But if it's about safe care and I'm least likely to make an error, I'm least likely to hurt a patient, I'm hopeful, and maybe I'm living in an ideal world, but I've been living in it for a long time. If I'm expecting staff to take good care of patients and less likely for them to make a mistake and hurt somebody, holy moly, that better be enough. That better be what's in it for me. You're not going to hurt. Let's just say you're not going to kill a patient, all right? The second part about the ED, ask me that question again.
So in the ED world, they're worrying about the next patient through their doors. So when it comes to providing safe care, they're kind of dealing with the patient that's going to another unit, plus dealing with the patient who's yet to come through their doors. So what's been some successful strategies, what you have used to address what's in it for me, to be sure that the ED is providing the two-way handoff?
I've seen it, the only way that I've seen it really work successfully is the expectations are laid down that, yes, we're going to get this patient out of the ED, and the expectation is that the receiving unit receives that patient within a certain period of time from the time that the decision is made or that the bed assignment is made, and that the expectation is really clear. And so the only way to help the ED is to for them to be able to predict that, yes, the bed assignment has been made, and I'm going to be able to move that patient within 15 minutes so that I can plan to move that patient within 15 minutes because the ED nurse is taking care of other patients. What I most often see is that if the patient's going to the ICU, they go with a nurse, and even then, not always a nurse that has provided care for that patient. And I really hate that. I mean, I just really hate that because the receiving nurse says, well, did you give them the insulin, or did you do this, or did you do that? And then transporting nurse says, I don't know, I wasn't taking care of this patient. How helpful is that? So if at least for the critical patients, if it's the same nurse that's been caring for them, can take the patient to the receiving unit and somebody backfill that nurse's assignment while they're gone in the ED, then that's most helpful. Frankly, that would be ideal for the med-surg transfers, but that doesn't happen. They go up with transport, so at least it needs to be a telephone report. But it has to go in a timely manner so that the ED, the only gain they get out of it is that they know the floors are not going to stall or put them off or slow down receiving that patient. The bed assignment's made, they're moving within 15 minutes, they can predict, they can plan, and get them out of there. That's the only benefit for the ED, is get them out of there quickly. And, you know, that's the best I've got. The most successful units that I have seen that make that happen involve the charge nurse when there's a charge nurse on the receiving unit. If the receiving nurse cannot take the patient, and I mean like right now, the charge nurse has to take a report and start taking care of that patient until the receiving nurse is freed up to lay hands on. That's the best answer I got for you.
Well, thank you so much, Jean. We really appreciate your information this morning. And since it's 11 o'clock, it looks like we also don't have any further questions. I would like to thank everybody for joining us today. And with that, I will be closing the meeting. Have a great day.
Thank you.